Imagine a surgeon needs to stop a bleed deep inside your digestive tract.
Right.
But instead of reaching for a scalpel or, a snare or a suture, they use a tool that never even touches your tissue.
Which sounds completely counterintuitive.
It really does. Instead, they harness a controlled, basically a miniature bolt of lightning.
Yeah.
So today, we are taking you on a deep dive into a procedure that completely redefines our mechanical expectations of medicine. It's called argon plasma coagulation, or APC.
APC, yeah, it's an incredible technique.
It's essentially a masterclass in manipulating physics. We're talking about using inert gases and high-voltage electrical currents to heal tissue, stop internal bleeding, and even destroy tumors.
Absolutely.
And to guide us through exactly how this is done, we're drawing directly from a really fascinating, highly detailed source. It's a YouTube video transcript titled HTC 1975-31 Argon Plasma Coagulation by Dr. Gautamukula S. Raju.
It's a phenomenal breakdown. I mean, understanding APC really requires us to look past that traditional model of medicine, the blade and the stitch, and step fully into the realm of biophysics.
Yeah, totally different ballpark.
Exactly. We are talking about engineering a bridge of ionized gas just to deliver thermal energy across a physical gap, all while navigating the really unpredictable environment of the human gut.
Okay, let's unpack this. Because APC balances this incredible life-saving precision with the literal risk of internal explosions.
Yes, literally.
The source categorizes the procedure as a monopolar electrocoagulation and a non-contact thermal coagulation therapy.
What a mouthful.
Right. But that non-contact aspect is what we need to figure out first. If the probe never actually touches the stomach or the colon wall, how does the electricity cross the gap to do its job?
Well, that raises an important question, and the answer is entirely dependent on the argon gas itself. The setup requires a specialized electrosurgical generator. And this generator isn't just a basic power source, it's simultaneously delivering two very distinct things down the catheter.
The gas and the electricity.
Precisely. A steady flow of argon gas and a high-voltage monopolar electrical current. Now, argon in its natural state is an inert, non-conductive, noble gas. It doesn't do anything on its own.
It won't carry a charge.
Right. But when that high-voltage current hits the gas stream right as it exits the tip of the catheter, this massive physical transformation occurs.
It ionizes the gas, right?
Exactly. The electrical current is so intense that it literally strips the electrons away from the outer shells of the argon atoms.
Wow.
And that process of ionization converts that stream of inert gas into a plasma.
And plasma is conductive.
Highly conductive. It becomes the medium for the electricity. So the current uses that stream of plasma to jump from the metal tip of the catheter across that 1 or 2 millimeter physical gap directly into the targeted tissue.
So that's the non-contact mechanism.
That's it.
So if I'm picturing this for you listening, the argon plasma is acting almost like an invisible copper wire connecting the probe to the tissue.
I love the copper wire analogy because it perfectly captures the conductivity, but it actually isn't invisible at all.
No, it's not.
No, because of the energy released during ionization, the plasma forms this highly visible, really intensely glowing blue or purple beam.
Oh, wow. So they can actually see the lightning bolt.
Oh, yeah. The endoscopist can clearly see this glowing beam striking the tissue. But the term you mentioned earlier, monopolar circuit, is critical here.
Right, because the energy has to go somewhere.
Exactly. Once that electrical current crosses the glowing plasma bridge and hits the mucosa, the energy doesn't just vanish. The human body actually has to become the return path for the circuit.
Which means the patient has to be physically hooked up to the generator in another way to complete the loop.
They do. The patient is connected to a returning electrode, which is typically just a neutral socket pad placed on their skin, like on their thigh.
Okay, I've seen those.
Yeah, so the high-frequency current flows from the generator, down the endoscope, across the plasma beam, into the target lesion, safely through the patient's body tissues to that neutral pad, and then right back to the generator. It's a continuous closed loop of energy.
And the generator is managing some incredibly specific parameters to maintain that loop without, harming the patient.
Oh, highly specific.
According to the source, we're talking about regulating the gas flow, often around 0.8 liters per minute, while simultaneously capping the electrical current at something like 30 watts for standard procedures.
That synchronization is really the heart of the technology. I mean, think about it. If the gas flow is too weak, The plasma bridge collapses, and the electricity just has nowhere to go.
Right.
But if the wattage spikes uncontrollably, the thermal energy will cause catastrophic tissue damage.
That sounds terrifying.
It can be. The generator acts as the brain, constantly balancing the physical push of the argon with the electrical charge to maintain the structural integrity of that plasma beam.
Which naturally brings us to how the doctor, the endoscopist, controls that beam on the front lines. The machine has several distinct firing modes, meaning it isn't just a basic on and off switch.
Far from it.
So forced APC is the first one discussed in the transcript, and it seems to be the really heavy hitter.
Yeah, forced APC is designed for maximum impact. In this mode, the generator delivers a continuous, completely uninterrupted stream of argon gas and high voltage current.
And they crank the power up for this one, right?
They do. Endoscopists might push the power significantly higher in this setting, sometimes up to 70, 80, or even 90 watts.
Wow, compared to the standard 30.
Exactly. You use forced APC when you need to rapidly overwhelm a target. Like if you're destroying dense tumor tissue or aggressively trying to halt an active, really heavy bleed.
You just need that raw power.
Right, you need that relentless thermal delivery to rapidly coagulate the proteins in the tissue.
Okay, so if we think about this like nozzles on a garden hose, forced APC is twisting it to that hard, continuous jet setting.
That's a great way to look at it.
But then you have pulsed APC, which alters the delivery. The generator interrupts the gas and the current, creating what Dr. Raju describes as a literal buzz, buzz, buzz effect.
Yes, the pulsing.
Right. And you have effect 2 for fast, frequent pulses and effect 1 for less frequent ones. So sticking with the hose analogy, this would be the sprinkler setting.
The sprinkler setting translates really well here because pulsed APC is all about surface area management.
Makes sense.
A continuous jet might drill way too deep if you're trying to treat a broad, flat area. By pulsing the plasma, the doctor can sweep the beam across widespread, diffuse bleeding without concentrating too much thermal energy in a single microscopic spot.
And what kind of conditions require that?
It's highly effective for things like gastric antral vascular ectasia.
Also known as GAVE.
Right, GAVE. That's where the stomach lining is covered in this network of superficial, really fragile bleeding vessels. You want broad coverage, not deep penetration.
Okay, so then there's the third mode, precise APC. In this setting, the generator actually micro-adjusts the power output based on exactly how close the catheter tip is to the mucosa.
This is where the tech gets really impressive.
It's essentially a smart nozzle that dynamically alters the pressure to guarantee the exact same impact, even if your hand is shaking or the distance changes.
What's fascinating here is the biological necessity behind that specific mode. I mean, in a vacuum, holding a probe exactly 1 or 2 millimeters away from a target is simple.
Sure, on a test bench.
Right. But an endoscopy is performed inside a living, breathing human. With every single respiration, the diaphragm moves, the stomach shifts, and the colon walls expand and contract.
I didn't even think about that. The respiratory movement alone makes holding a static 1 millimeter gap basically impossible to maintain manually.
It's incredibly difficult. The endoscopist is manipulating a flexible catheter down a 4-foot tube, trying to hover over a target that is constantly undulating.
Just bobbing up and down.
Yeah. If the catheter gets slightly further away, the plasma bridge might just break. If it gets slightly closer, the thermal damage might spike dangerously.
So precise APC fixes that.
Yes. Precise APC calculates that fluctuating distance in milliseconds through the impedance of the circuit. It automatically throttles the wattage up or down so the actual thermal effect on the tissue remains perfectly constant, regardless of the patient's breathing.
That level of hardware intelligence is staggering.
It really is.
And speaking of the hardware, the physical catheters themselves are highly specialized. The source notes that endoscopists are dealing with probe lengths of either 220 centimeters or 440 centimeters.
Depending on how deep they need to go.
Exactly. And they typically prefer the 10 French width rather than the smaller 7 French. And that's simply because the 10 French fits snugly into the working channel of most standard endoscopes, which just gives them better physical control.
And control is everything here, which is why the firing tips of those catheters are also uniquely designed.
Because anatomy isn't a straight pipe.
Exactly. The human gut is full of twists and turns. A doctor might need a straight fire catheter for an axial beam when they are looking directly at a lesion. But what if a bleeding vessel is tucked just around a sharp fold in the colon?
They can't just bend the light beam.
No, so they need a side-fire catheter that literally shoots the plasma out at a 90-degree angle. They even have circumferential fire beams that create a complete 360-degree halo of plasma.
A halo of plasma.
Yeah.
That highlights a huge logistical point, though. The communication between the doctor and their technician.
Oh, it's vital.
I mean, if the endoscopist needs to hit a lesion straight ahead, but the assistant accidentally hands them a side-fire catheter, they're going to blast a glowing plasma beam directly into healthy tissue on the sidewall.
Which would be disastrous.
Right. The assistant has to verbally verify the catheter length, width, firing direction, generator mode, gas flow rate, and wattage before that probe ever even enters the body.
It serves as a great reminder that all the millimeter-precise micro-adjusting technology in the world still fundamentally relies on two humans in a room communicating clearly.
Very true. So, armed with this highly specific arsenal, what exactly is the end game inside the digestive tract?
Well, there are a few main targets.
We know they use it for hemostasis, stopping bleeding in conditions like GAVE, which we mentioned, or radiation telangiectasia in the colon.
Right.
But they also use it for post-surgical sterilization. If an endoscopist performs an endoscopic mucosal resection, an EMR, to cut out a precancerous lesion, they'll actually use the APC beam to ablate the margins of the defect.
Yeah, it's basically a microscopic scorched earth policy.
Scorched earth.
Basically, yeah. When you physically resect a lesion with a snare, there's always a microscopic risk that some rogue dysplastic cells are left behind on the edges of the cut.
And they could grow back.
Exactly. So by painting those margins with the argon plasma, the thermal energy destroys any residual cellular structures, which significantly drops the recurrence rate of that specific tumor.
But the application that really stands out in the video is for Barrett's esophagus. Radiofrequency ablation mostly replaced APC for Barrett's, but APC is making a comeback, utilizing a very specific technique.
And it's a really clever technique.
Well, before firing the plasma, the doctor actually injects fluid directly underneath the Barrett's tissue. And I have to push back on the logic there.
Oh.
We are dealing with high-voltage electricity inside the human body. Injecting a pocket of fluid right where you are about to shoot an electrical beam seems like a recipe for unintended conductivity, like dropping a toaster in a bathtub.
It does seem counterintuitive, definitely, until you analyze the layers of the gut wall. What's fascinating here is that the fluid injection isn't acting as a conductive spread. It is actually acting as a physical and thermal barricade.
Oh, interesting.
Yeah, this technique directly addresses the single most dangerous aspect of argon plasma coagulation, managing the physics of thermal destruction in a highly constrained environment.
Right, because the digestive tract is paper-thin in many areas. It's not just a solid block of muscle.
No, it is very delicate.
How do they actually avoid burning a hole straight through the patient?
Well, they have to master three distinct variables of damage. The first is distance. We established that 1 to 2 millimeter hovering gap earlier.
Right, it's non-contact.
Exactly. If the endoscopist pushes too close and actually touches the mucosa with the probe while firing, the physical pressure of the argon gas, which is flowing at nearly a liter per minute, gets forced directly into the submucosal plane.
And the transcript mentions this causes a pneumatocyst.
Yes. The gas literally dissects the tissue layers apart, creating this trapped pocket of argon within the gut wall.
Oh, that sounds awful.
It's a complication you desperately want to avoid. So that's distance. The second variable is power, or wattage. The higher the watts, the deeper the thermal burn. Simple enough.
Sure.
But the third, and unequivocally the most critical variable, is duration. Time.
The actual amount of time the physician keeps their foot pressed on the generator pedal.
Exactly. The physics of thermal injury are strictly mathematical. Let's look at the joules.
Okay, let's do the math.
If the generator is set to 45 watts and the endoscopist activates the plasma beam for exactly 1 second, they have delivered 45 joules of total energy to the tissue.
Okay.
That specific energy load creates a safe, superficial coagulation. It destroys the mucosa and barely grazes the submucosa beneath it.
But if they keep their foot on the pedal for 3 seconds instead of 1...
At that same 45-watt setting, a 3-second duration delivers 135 joules of energy.
Triple the heat.
Exactly. That heat load doesn't just spread out across the surface, it penetrates downward. It burns completely through the submucosa and strikes the muscularis propria, the deep muscle layer of the organ wall.
And the margin for error there is terrifyingly small, depending on the anatomy you're working with.
Oh, absolutely.
Take the cecum, for instance. The cecum is located right where the small and large intestines meet, and the wall there is incredibly fragile. Dr. Raju mentions a total thickness of roughly 2 to 3 millimeters.
Think about that. That is the thickness of a couple of stacked credit cards. If a patient has a bleeding cecal angioectasia, the endoscopist has to be flawless. If they hold that pedal down for 3 seconds, that 135 joules of thermal energy will cook right through that 2-millimeter wall.
And the scary part is they might not even realize it right away.
Right. The lesion might look perfectly coagulated on the monitor, but the deep tissue architecture has been completely destroyed.
Which leads to deep thermal injury, post-polypectomy syndrome, or a delayed perforation. So to solve this in such a thin environment, they rely on that fluid injection technique we mentioned earlier with Barrett's.
They do. They use a specialized endoscopic needle to inject a submucosal bleb.
A bleb.
Yeah, a fluid cushion, basically, directly underneath the bleeding lesion. And the fluid of choice is usually just saline or sometimes a highly diluted epinephrine mixture around 1 to 100,000 or 1 to 200,000.
Okay, here's where it gets really interesting. Because if I'm visualizing the physics of this, that saline injection is acting like a thermal heat shield.
Exactly like a heat shield.
Imagine taking a blowtorch to a single sheet of loose-leaf paper.
It incinerates instantly.
Instantly. But if you slide a thick phone book under that piece of paper and hit it with the blowtorch, the paper still burns, but the phone book absorbs and dissipates all the excess heat, protecting whatever is underneath.
That's a perfect way to visualize it.
So the saline bubble literally lifts the mucosal lesion away from the deep muscle layer and just eats the thermal energy.
The phone book analogy works really well for the physical separation, but the fluid is dynamic. It actively absorbs and dissipates the heat rather than just blocking it statically.
Right, because it's a liquid.
And the addition of the dilute epinephrine introduces this brilliant biochemical advantage. Epinephrine is a powerful vasoconstrictor.
It shrinks blood vessels.
Exactly. When it enters the submucosal space, all the tiny, irrelevant background capillaries just clamp shut and visually vanish from the endoscopist's monitor.
Oh, it clears the visual noise.
Precisely. It isolates the primary feeding vessels of the lesion. The doctor now knows exactly where to aim the plasma beam, meaning they can apply significantly less thermal energy overall.
That is so smart.
It really is a seamless integration of chemistry, physics, and anatomy, all working together to protect a 2-millimeter biological wall.
So what does this all mean for the patient? I mean, we have dynamic generators micro-adjusting wattage in milliseconds. We have submucosal saline heat shields. We have calculated joules of energy. It paints a picture of a procedure where the risk has been engineered entirely out of the equation.
You would hope so. But, that is the danger of advanced technology. It creates a false sense of absolute security.
It's never zero risk.
Never. The reality is that introducing a continuous flow of non-absorbable gas and high-voltage electricity into a closed biological environment carries extreme, sometimes lethal, inherent risks.
Yeah.
Even with perfect technique, the physics of the environment can turn against you.
And the source points out that the non-absorbable nature of the argon gas is a massive hurdle all by itself.
Huge hurdle.
During a normal colonoscopy, doctors inflate the gut with carbon dioxide just to see what they are doing. CO2 easily absorbs into the bloodstream, and the patient simply exhales it naturally.
Right, very safe.
But argon gas, being inert, doesn't diffuse into the body. And the machine is pumping in up to 2 liters of it per minute.
Which forces a really strict operational protocol. The endoscopist must actively deflate the colon, suctioning out all the existing CO2 or room air before they even begin firing the plasma.
Wow, they have to empty it first.
They do, and while they are working, they have to constantly suction the argon back out. If they fail to manage the gas volume, the argon just sits there, completely trapped in the digestive tract.
And what happens to the patient?
Well, the patient will wake up in the recovery bay experiencing excruciating abdominal pain and severe bloating just from the massive distension.
Ugh, that sounds incredibly painful. But the complications from the thermal energy itself could be incredibly insidious too. We discussed the risk of burning the deep muscle layer, leading to a delayed perforation. But the terrifying part is the word delayed.
Yeah, that's the part that keeps doctors up at night. The tissue doesn't always tear instantly.
It doesn't.
No. The immediate post-operative monitor might show a perfectly intact, albeit coagulated, gut wall. The patient is discharged and they just go home.
Thinking everything went great.
Right. But over the next 2 to 3 days, that deeply heat-damaged tissue begins to necrose and physically break down. When the wall finally gives way, the perforation occurs entirely outside the view of the medical team.
And because the initial hole might be microscopic, the patient might just feel a dull ache and assume it's normal post-procedure soreness.
Exactly. They might just ignore it.
They ignore it. But internally, digestive contents and intestinal bacteria are slowly leaking directly into the sterile abdominal cavity.
Which is a medical emergency.
It leads to fecal peritonitis,
Yeah.
a massive systemic infection that rapidly becomes fatal if emergency surgery isn't performed.
A very grim reality.
But somehow, even fecal peritonitis isn't the most shocking risk factor in this deep dive.
No, it actually gets worse.
Reading through the breakdown of treating conditions like radiation telangiectasia in the colon, this next detail requires complete, unquestionable operational discipline.
Yes, it does.
If a patient is undergoing colonic APC, they must complete a full, absolute bowel preparation beforehand to clear out every single trace of natural gas. Why? Because human beings naturally produce methane gas in their colon.
Yes, we do.
And methane is highly flammable.
Extremely.
If an endoscopist fires an electrical plasma beam into a colon containing trapped methane gas, the electrical spark will actually ignite the methane. The term Dr. Raju uses is fatal colon explosion.
If we connect this to the bigger picture, it beautifully and honestly somewhat terrifyingly illustrates the paradox of modern medical advancement.
Paradox how?
Well, we have developed the capability to stop massive internal hemorrhaging without ever making a surgical incision, simply by manipulating the atomic structure of an inert gas. It is borderline miraculous.
It really is.
But human biology is ancient and complex. Some patients have gut microbiomes that are incredibly dense with methanogenic bacteria.
Meaning they produce a ton of methane.
Right. When you introduce a high-voltage plasma laser into an environment biologically primed to produce flammable gas, you create a hazard that simply did not exist in the era of the mechanical scalpel.
That's a great point. A scalpel doesn't spark.
Exactly. It mandates that medical professionals remain relentlessly hypervigilant about the most unglamorous foundational details. Ensuring a patient drank every single drop of a terrible-tasting laxative isn't just about giving the doctor a clean camera view anymore.
No, not at all.
In the context of argon plasma coagulation, a perfect bowel prep is the only thing preventing a combustible catastrophe.
It radically changes how you view standard pre-op instructions, for sure.
It really does.
So, looking back at what we've unpacked for you today, we started by breaking down how a specialized generator strips electrons from inert argon to create a conductive, glowing bridge of plasma.
The miniature lightning.
Exactly. We explored the brilliant engineering of precise mode, automatically adjusting electrical output millisecond by millisecond to account for the simple act of a patient breathing.
A true technological marvel.
We examined the physics of thermal destruction, calculating joules of energy to ensure a 2-millimeter tissue wall isn't breached, and utilizing submucosal saline injections as biological heat shields.
The phone book analogy.
Right. And finally, we confronted the unforgiving reality that failing to manage something as basic as natural methane gas can turn a life-saving tool into a fatal ignition source.
It is just a phenomenal demonstration of applied science.
Mm-hmm.
And I think it leaves us with a profound shift in how we perceive healing itself.
How so?
Well, we have been conditioned to think of surgery as an inherently physical, mechanical act. You know, the physical removal of a tumor, the mechanical suturing of a bleed.
The blade and the thread.
Right. But procedures like APC prove that the frontier of modern medicine is increasingly about mastering the invisible forces around us. It's about manipulating atomic conductivity. It's about mathematically mapping the thermal threshold of a microscopic cell layer.
It's physics.
It's pure physics. It makes you wonder, as technology accelerates, how much more of our medical future will rely on manipulating the physics of the invisible rather than wielding the steel of a blade.
That is a phenomenal question and exactly the kind of thought we love to leave you with. Next time you think of surgical intervention, maybe picture a glowing plasma beam instead of a scalpel. Thank you for joining us as we explored the miniature lightning storm saving lives inside the human body. Keep learning, keep questioning, and we'll see you on the next deep dive.